Hello, everybody. This is the sixth, I think, and seventh and last of the World Heart Federation's World Heart Cafes on emerging issues in cardiovascular health. Today, this one is on protecting cardiovascular health in a changing climate. I think this is something we've all been noticing is coming up more and more at various conferences and discussions that we have been at. And let's say it's certainly an emerging discipline in the world of these conferences. My name's David Lloyd. I'm CEO of the National Heart Foundation in Australia. I'm also a member of the World Heart Federation board, and it's in that capacity, certainly not my capacity as an expert, that I'm here today. We have three people here on the panel, though, who are experts. Maria Nera is director of the Public Health and Environment section of the World Health Organization, and astonishingly has been in that role since 2005, you might say, since before it was fashionable, I suggest. So well done for that, and we're really looking forward to hearing you on that. Hatim Kermis is a cardiology resident at the German Heart Center in Bremen, and he has a research focus on MI, on primary and secondary prevention, particularly with an interest in noise and air pollution. And then heading over to Georgia Chaseling, you will notice when she starts speaking that Georgia is also an Australian. She is a cardiovascular and thermal physiologist from the University of Sydney with special interests in the influence of heat and exercise on cardiovascular health. She's also a member of the World Heart Federation's expert committee on air pollution and climate change, which is where these things get developed. It's worth saying before we get going that the character of these discussions, and I've sat through a few of them now and learned this, which I must say I've really enjoyed, is very discursive. It's not didactic, and they are, perhaps I'd even say, fireside chats that at their best, I think, involve a certain amount of audience participation as well. I also wanted just quickly to say something about the way the World Heart Federation does this. I've been involved with the World Heart Federation for a relatively short period of time, but these discussions emerge from policy documents and roadmaps and other artifacts of the World Heart Federation, which are very, very, very implementation focused. The World Heart Federation produces documents so that they will be picked up at national and international and multilateral levels and used and worked. And so this discussion stems from a commitment that the World Heart Federation made through the publication of a World Heart Report on air pollution and climate change that was launched at the World Heart Summit in Geneva in May of 2024, produced by, the group was chaired by Mark Miller, and some of us have heard Mark speak about that. And it's really that started this off, and when we have this kind of conversation, we will be thinking very much about how these ideas are picked up and then used. These are not studies. These are things that will be picked up and we hope implemented in country. So this world of air pollution and climate change and the impact it's having on cardiovascular health around the world involves, I'm going to start with you, Maria, if I may, involves a mix of disciplines which, generally speaking, don't have each other's language, I feel. You've got energy, transport, and agriculture as the disciplines within which the evidence is being developed, and then the policy and implementation world is that of health. And I wondered if you could reflect a little bit on whether they have each other's languages and whether the evidence and policy people are actually able to communicate well enough yet.
Yeah, thank you, David. Can I call you David?
Yes, you may. Yes.
Thank you. Thank you very much, and a pleasure to be here. Talking about languages and different languages that we all use at different communities, it took us almost 20 years to reach the level of the COPs, the Conference of the Parties on Climate Change. I still remember the first ones that we were attending as representatives of WHO. We were trying to run after the delegates and the negotiators because we wanted to explain them how important climate change was for our health. And they were looking at us very say, who are you? Say, why the World Health Organization? And we say, because this is all about health. Little by little, the interlinkages between health and climate change were started to be more and more clear. For us, obviously, the overlap between air pollution and climate change is obvious because the causes overlap almost 75%, and it's about accelerating transition to clean sources of energy, it's accelerating transition to healthy urban planning and development, and it's accelerating transition to sustainable food systems. All of that are the pillars of our health, for cardiovascular, for respiratory, for neurological. All our health will be suffering if we were not doing that. So that's why we're spending a lot of time trying to learn the language of the climate change community. And for instance, we discovered that when the climate change community talk about mitigation of the causes of climate change, I'm sorry, but this is something that we have invented, the public health community, ages ago, and we call it primary prevention, correct? This is primary prevention. Adaptation, when I was explaining 20 years ago what adaptation means and resilience, I said, sorry, this is, by the public health community, is called secondary prevention. So fantastic. This is the language we need to adapt and learn, use theirs, but incorporate that. The second language that it was very difficult was to make sure that people understand that they were negotiating, because when they go to the COPs, they negotiate with the level of emissions, the percentages. By the way, they have been negotiating for 30 years. Do you think that it was a public health issue? If we take more than 2, somebody will accept it in the international community. We will be absolutely frustrated. If it takes a public health treaty, will take more than 2 years, we will be totally frustrated. So the language we start to use is say, okay, this is terrible, this is affecting our health, climate change. However, if you take this measure, and this measure, the benefits for health will be enormous. So we started to use what we call the health argument. So when you tell somebody that if you reduce the emissions, in fact, what you are doing is to reduce the cardiovascular diseases, to reduce respiratory, obstructive pulmonary chronic conditions, you reduce a big amount of diseases that we are now suffering because of climate change, then they start to have some connection. So my recommendations in terms of language is to be very pragmatic, use the health argument, making sure that we explain our benefits for health instead of course, we need to describe what are the negative impacts of climate change on health, but as important of that is to tell them how much we can obtain to protect health and to prevent diseases if we invest on the right transitions of energy, transport, and others. So languages can be aligned. And today, at the COPs, health is very, very, very prominent.
So that's interesting because it seems to me we're here because the health lobby has picked up the climate argument. Is the climate lobby picking up the health argument very much? I have to say probably not in Australia.
No, but they are learning now. And in fact, there are many politicians, starting, for instance, with mayors. Mayors understand now that when they need to take certain measures that are not very popular, like traffic related to reduce air pollution, if they use the health arguments, if they explain that if you do so, there will have enormous benefits for our health, then bingo, we have a very good communication there.
That's good to hear. Hatim, are you starting to see this in the clinic yet?
Yes. Thank you, David, for your question. So let's say in the last 20 years, the cardiovascular field had a big transformation, more evidence, more guidelines, and it's good, it's positive, but there is a little research about the climate change, environmental, cardiovascular diseases, and I still see regularly patients that comes with in heat waves, for example, heart failure patients that come decompensated, they are dehydrated, they are They have acute kidney disease, kidney injuries due to heat waves. I see my patients, even we have in Bremen, we are classified as a city with a fair air quality, and even in our city, we see that days with exceedance PM2.5 levels, a higher incidence of myocardial infarction incidence. It triggers infarction, it triggers strokes. It causes decompensation for our patients. There's now little bit evidence that it could cause also rhythm disorder. So we see that regularly, and let's see, I can cite a statistic from the Europe. We have more than 60,000 people died during the heat wave in 2022. So it's not a little. And I think this is underestimated. I think environmental exposures causes more death, more harm, and we need to focus on it and more research on that field.
Sorry, can I ask what is listed as the cause of death there in the 62,000? What was identified as cause of death? Was it pollution? Was it climate? Or was it simply cardiovascular disease?
That was mainly due to cardiovascular disease, and mainly people who had established cardiovascular factors and diseases. There are vulnerable population. We'll speak later about what we could say to our patient to mitigate that problems. Now, let's say it's a global problem, but we can say also in a microclimate plays also a role. We cardiologists, we speak maybe more about macroscopically climate changes. In heat waves we have problems, but microscopically in part of cities which more dense, where little bit greenery, little free corridors, we can see, we saw in our study in Bremen that young patients get heart attack, get myocardial infarction, even they have low exposure to cardiovascular risk factors, and afterward they had a substantial, big influence in the long-term prognosis. So it's not an abstract. It's not an abstract concept. It really exists. It's real. We need to be aware for it. We need to see, we see it in our clinic. We are not aware of it because we don't do a lot of research about it. But when we get data, when we see what data says, then we remark that the difference, and we are aware that not only smoking or diabetes or cholesterol plays a role, but also climate change, microclimates, air pollution, noise exposure. Those factors are game changers.
Remind me to be provocative later on.
You can be provocative now if you like. Yeah, go
for it, please.
Go.
Is that okay? No, because I think the important thing here is we know that we will have heat waves very often. Unfortunately, in Australia, in Europe, now we are having more and more heat waves. I think medical doctors of different specialty, we know what that represents, as you say, on the micro or the macro. I am missing the voice of cardiologists going in to talk to the media and say, or to politicians and saying, this is about health. This is not just about the planetary issues. This is not about believing, or not the passion. On climate change. It's about what politicians need to be to prepare for those heat waves, to reduce air pollution. And I would like to see more the voices of the health professionals being provocative, being more outspoken, and being convinced as well that this is something that is our business. It's like if we were treating salmonella cases, every day and treating the patients without raising our voice to say, hey, something has to be done in terms of food safety because we are seeing an increase on the salmonella cases. Sorry.
No, look, I mean, I have to say I completely agree. I run a heart foundation in Australia. We yet aren't talking to the climate minister. We're not talking to the energy minister. We will be soon. I have to say we will be after this. But it is really important that we take our health argument to the portfolios in which they can be dealt with.
I'll jump on that too.
Go on.
It's interesting. I was telling David yesterday, I ran into a cardiologist on the train, we got chatting, and so I do my research in the impact of heat on cardiovascular health, and his question was, does anyone care about it? And he clearly didn't. And it was very eye-opening, and I found myself sitting there on the train drilling into him the importance of it and the impact of heat on heart health, just because that's my specialty. But I think I completely agree. Cardiologists aren't speaking up. Some are aware of the impacts, but a lot of them aren't aware, or they just don't see it as a priority. So yeah, it's going to get hotter, and it's a lot more people are going to get sick, and it's just not a priority for them, and it's frustrating. But
it's great that you're doing advocacy one stray cardiologist at a time on the train. I love that. That's really good. But I mean, it strikes me that, Hatim, you're talking about cholesterol and smoking. We have guidelines for these things. We have documentation. We have policy. We have advice that we give to clinicians. Georgia, are you seeing this turn up in guidelines or in similar policy that we provide to clinicians yet? I mean, you talk about it a lot, but I don't think you can do the entire cardiology profession one at a time.
No. Unfortunately, specifically focusing on heat health guidelines, there's almost nothing that's specific for people with cardiovascular disease. And we've done a lot of research now to look at the guidelines, what's the efficacy of them, how much are they backed by scientific evidence. And a lot of the time they're generic. They lack specificity. They don't account for individualized cardiovascular diseases, medication intake, exercise. So while some of the generic guidelines can apply to people with cardiovascular disease, unfortunately, at the moment, we're not supporting people with cardiovascular disease in the context of climate change. Air pollution to an extent as well. I know the World Heart Federation has released the roadmap, but this is just within the year. And so when it comes to air pollution as well, we're only just starting to get the wheels in motion. So there's really, really not a lot there. Having said that, I don't think a lot of people with cardiovascular disease are even aware that they are at risk to look for guidelines that would be specific to them. So there's kind of this double-edged sword where you need to advocate and educate, and then we need to deliver the goods so that we can protect this population.
That sounds like something which might take a number of years, but it's good that we've started.
Yes.
It's good that we've started now. Maria, I want to come back to you and talk. We've talked a bit about Australia because we were bound to do that with two Australians on the panel, but you've had a lot of experience in emergency and crisis situations of massive population displacement. And just before we started this, I was saying to you that about 10 minutes before we all got locked down for COVID, I had an opportunity to visit the Rohingya camp in Bangladesh. And at that time there were, I think, 800,000 people. I think it's over 1 million people now. And the cholera and polio vaccinations were up to about 98%. There was rudimentary housing, but absolutely nobody was thinking about the chronic disease implications of being in a highly polluted, highly stressful environment and not having a massive hope of going home anytime soon. And what some people in chronic disease were starting to say was, this 10 years out is an absolute cardiovascular disease disaster. Do you have any views or indeed experience in this?
Yeah, thank you. I started my career working on refugee camps. So I worked for many years on refugee camps in Africa, Central America. And I can confirm what you are saying. When you work on a refugee camp with displaced population, the tendency is to think about infectious diseases. And this is common, I'm afraid, in all the emergencies. You will focus very much all of your efforts, interventions, resources into outbreaks. That's the first. And you will be even disappointed if you don't have outbreaks, because then where is the emergency? Excuse me. Sorry, I'm trying to be provocative again. But seriously, we need to make sure that when you work on displaced population, people living under stressful situation, not going out for 8 years. I've been in Central America, people never been out from the refugee camp in 8 years. So imagine the stress and the rest. But my interest and connection on the non-communicable diseases was that I was stupidly treating every week little children with asthma, okay? And then I was doing my best to treat it. But then one day, fortunately not too late, I say, okay, I need to go and see why they are having these very serious acute asthma cases. And then, of course, they live in a place, let's be honest, a place where they were cooking inside with an open fire and no ventilation. I mean, of course, they were having all type of respiratory diseases, including asthma, and that's preparing for future cardiovascular diseases. So what I did, I fight with the guy who was responsible for UNHCR, so for the refugee camps, and say, okay, we need ventilation, and we need to create a place where all women will cook together, and then instead of each of them having an open fire, we cook, we prepare something with a minimum of ventilation. The guy of UNHCR at the beginning says, well, come on, this is not feasible. And now we are married. After 33 years, we're still married. So he accepted to do an open kitchen for all the women with ventilation, with better improved cooking facilities. And that was my way to realize that you need to work on risk factors, even if you are on an emergency situation. But unfortunately, when you are on an emergency situation, the priority will be on vaccines, and if you are lucky, in providing clean water, and then infectious diseases. But very, very, very little about non-communicable diseases. But again, our voice here is very important.
Yes, I think it's certainly it's very important for us to think about these environments and the scale that they present themselves to us at. We were talking at the advocacy committee of the World Heart Federation last year about the fact that the displaced population of the world, if you put it as a country, is actually the 5th largest country on earth. So it's not a population that we can ignore. Hatim, you're a resident, and so you've got recent experience of the world of cardiology education. Is cardiology education keeping up with this, and is there stuff, or is there more that cardiology education could do?
Unfortunately, I could say doctors want to act, want immediate results. So cardiology is more changes through interventional things. We get a lot of experience about TAVI, about clips. We could help, we could surgery, but prevention is very important. Prevention, we could prevent those diseases, and it is very important. We learned in the medical school a lot about classical risk factors. The myocardial infarction should be treated as soon as possible. Time is muscle. Everything is okay. It's very important. But if we prevent this myocardial infarction, this heart attack don't happen. So we learn a lot about diabetes, cholesterol, smoking, but we didn't have in the cardiology lecture in the university something about environmental exposure on their impact of the myocardial diseases. It's film. We don't have that subject. And so, this is the first point. Second point is the curricula of cardiologists. So every cardiologist should know how to talk with the patient about climate change and health, how to give advices during the heat waves, how to explain the risk of air pollution, how to reduce noise exposure at night, for example. Such advices could help our patients, that vulnerable patients, to mitigate their risk. So, and we need after all, and you're right, you say we don't speak about the risk factors because we are focused all the time about what we can intervene, but what we prevent, we don't talk a lot about it. So we need also a local research. We need as cardiologists, be active in the research, because we as cardiologists and patients think climate change is where else, and not, for example, in Europe. For example, when I speak, for example, in my daily practice with the colleagues or with the patients, they think they are not involved in that problem. So when we present local data, when I say we conducted a study in our city and we saw that patients are affected in the heat waves, and patients in microclimate unfavorable region don't need to have a lot of risk factors to get the heart attack. When we say that noise exposure is an independent cardiovascular risk factor, so my colleagues are convinced, my patient is convinced, he have a local data, so it seems concrete and convincible. So it's very important to combine, or let's say, let's sensibilize our medical student or medical professional about the impact of climate change. Let's sensibilize the cardiologist in residency, and let's sensibilize our patient based on real-world local data.
I think that's very interesting you say that, because you're talking there well beyond the climate change agenda. You're talking about prevention more broadly, and basically the environment within which people try to maintain their cardiovascular health and their clinicians try to support them in doing it. Perhaps going straight in at the start with air pollution and climate change is not the best way to open the discussion. Maybe it's better to have a broader prevention agenda where you can talk about food security, access to food, you can talk about heat, you can talk about noise, and air pollution becomes part of the discussion rather than the only environmental issue that you're talking about.
For sure. I think it's important to integrate it in our daily practice, to talk with people, to sensibilize not only patients but also health providers that climate change is not an abstract concept. It's real. It's harm our patients. So and we need to convince our society. We are not all convinced, and it's real. When I talk with colleagues, it's not. Let's say it's not natural. It's I need to convince my colleague that climate change plays a role in the cardiovascular disease. It's not simple to understand, for sure, but it is essential.
Yeah. So, Georgia, I want you to talk a bit, if you would please, about risk and how we identify the point at which things have got to a point where we need to do something. We're talking broadly about climate change, which is around us and which is clearly happening gradually. But on a hot day, and you're particularly interested in the thermal impact on cardiovascular health, on a hot day, there's a point at which it becomes too hot, where people have got to stop doing things, where they've got to go inside, where they've got to use water to cool down. Now, are we very good at knowing that point and then communicating that point yet?
To an extent, but also to an extent no. So how hot is too hot? We don't have a definitive number, and it really depends on the environment, the humidity as well, not just the ambient temperature, the radiant heat, the wind speed. So there's a lot of things that go into what environment will become not survivable anymore. There's some research happening at the moment that is looking at survivability limits for human health, and it's, it is extreme. About 50 degrees Celsius is where it starts to teeter on, this is no longer survivable for human health, or go inside. On a day-to-day basis, unfortunately, there's no research that really details how hot is too hot. The American Heart Association says on a hot day or during a heat wave, don't do anything, just stay inside, stay in an air-conditioned environment. European Society of Cardiology says a 30 degrees Celsius wet bulb globe temperature which is a combination of humidity and ambient temperature. But the problem with that is it can be any combination. So it can be 30 degrees Celsius and 10% humidity, or it can be 25 degrees Celsius and 60% humidity. So it's a dynamic number, it doesn't fit. And it's based on data in healthy individuals as well. So there's no kind of set how hot is too hot. Some people say don't do anything, any type of heat. Other people saying 30 degrees wet bulb globe temperature. So there is no answer.
I mean, it's an obvious point, but presumably the advice is different to me, my 28-year-old daughter, and my 90-year-old mother-in-law, right?
Yeah.
I mean,
yes. So pretty much anyone who's over the age of 60 has a decreased ability to regulate their body temperature. So a lot of the time when we look at how hot is too hot, you divide it between people under the age of 60, people over the age of 60, and then people on specific types of medication, people with diabetes, people with cardiovascular disease, and so forth. So that number is different. But the thing with cardiovascular disease is that age it's across the spectrum. So you can have people with congenital heart disease who are a lot younger. You can have older adults with heart failure.
It's a very crude measure.
Yeah. So it just doesn't sit.
Yeah, no, I think we forget a little bit the influence we can play here. I think we are focusing on our patients, and of course we can provide recommendations for our patients, and it's our responsibility, and then all the difficulty that you were describing and all of that. But the thing is, our patients, there is not much they can do to change the conditions in the city, for instance. It's not a behavioral issue. You have a patient that smokes, you can insist on and say, stop smoking. And then it's a decision of the patient, although we all know that the environment will force you or stimulate you to smoke. In the case of climate change and the heat waves, I think what we need to do with our patients as well is for them to be educated, to put pressure on their politicians, because they are the ones who choose the politicians and the ones they vote. What is unacceptable is that if you have a heat wave in Madrid, it's not a question of me staying at home. Of course, I can do it. Maybe I don't have air conditioning, so staying at home might be a very bad idea because it's super hot and all of that. So what we need to use our voice for, and this is where I'm saying that we are maybe not you cardiologists, that you are not aware of the influence you can play beyond your patients. This is something that you will not change as a patient. It has to be changed as a society. It has to be changed by politicians. It's unacceptable that we are moving to cities that will reach the 50 degrees. Unacceptable. So we need to do something about the causes of that. And for that, the voice of the health professionals is fundamental. Fundamental. Samantha, my colleague, Dr. Pecoraro from WHO, has worked on a training course for health professionals where we can help on telling the professionals how their voice can be very important, not only to advise patients, but as well to work with politicians, with mayors, with anyone, and really put a pressure and saying, we need climate places in the city where patients can go, patients or normal citizens, particularly those more vulnerable, to get some air conditioning or get a better conditions for preventing what the heat wave will bring. So we need the voice of the cardiologists very strong. In few weeks from now, there will be in New York the General Assembly on non-communicable diseases. I'm sure that you are all aware. It's fantastic. It's a big declaration, very political. And when I say political, means decaffeine. You know, this coffee that you are having there, you have a formula, which is decaffeine. Well, this is decaf. The declaration that will come out of this will be totally decaf. But still, no mention to air pollution. Excuse me? Non-communicable diseases. Air pollution is one of the biggest risk factors for health. The number 2 for mortality, the number 1 for morbidity. And we are not talking about air pollution. We are talking exclusively about the behavioral risk factors. So what as a patient I can do, but not what our politicians, our policymakers, our mayors, our whoever has the responsibility, all of us as consumers as well, to reduce the causes of air pollution, which are very much the same causes of climate change. And of course, we need to do that. And I'm very happy to have here the representatives from CDC China. They have done incredible things in Beijing, in Shanghai, in the big cities in China to reduce air pollution because it was a question of survival for their economy. For their economy, because when you have those heat waves and those air pollution levels, you don't have business. So whatever is your motivation, health is as well one of the biggest motivations that we need to use it, and we don't have time as we did for tobacco. Tobacco, it took us 50 years to reach the Tobacco Treaty Convention. We can't afford another 5 years for air pollution. Come on, it's responsible for cardiovascular diseases. We need to do something about, and it has to go beyond the behavioral changes in our patients. It has to go broad as a population-based measures, and our voice, particularly you clinicians' voices, are very, very powerful.
You were going to jump in there, I think.
I just had one comment to make, and I 100% wholeheartedly agree with everything that you say. The only thing that I'll kind of say to play devil's advocate is I do know that heat-related hospital admissions and death are preventable. Exactly. But can be on an individualized level as well. So while I completely agree with everything, I think there is an element of we can educate people to take individualized approaches in the interim, because while we can't change their ambient temperature, we can educate people on, okay, this is what you can do to prevent cardiovascular strain and thermal strain. There's a lot of research, particularly in Australia, 75% of people own air conditioning. But there's a lot of research that shows about 2/3 of people who own air conditioning don't use it because of fears of the costs associated with using it. So, air conditioning isn't the answer, and we need to figure out other ways when we, go down to an individual level on top of being a more, systemic problem.
Absolutely, both are absolutely critical.
Yes, and Maria, your point is well made about air pollution and climate change not being mentioned in the high-level meeting communique. I have to say, in the zero draft, heart disease wasn't mentioned either. So that things get lost in the language of NCDs. It's a permanent bugbear of mine. Decaffeinated, yes, I'm going to use that. That's great. There are some examples, and you're a very experienced diplomat and multilateral diplomat. You've seen countries work together. One thing I was reading in the paper, and I was reading the Australian paper only this morning, the island of Tuvalu is gradually moving to Australia. And there is an acknowledgement that they're not going to have a home within 50 years, and there's a lottery, and gradually the entire population is moving. That's pretty critical, but do you, and perhaps maybe a silly example of international collaboration on this, but have you seen many other examples of international collaboration on this which you think are worth organizations like the World Heart Federation picking up and supporting and advocating for?
The seeds, the small islands developing countries, they have been very outspoken on saying, well, this is about our survival, because for them it's a question of survival. The island might disappear, so they are moving into it. For me, the biggest achievement is when at the negotiations at the COP, because this is where we can have this famous global high-level influence that then will be translated. The thing is very important. If you look at the Paris Treaty, and this year will be the 10th anniversary of the famous Paris Treaty on the climate change. If you read all the recommendations, the interventions to mitigate climate change, this is our agenda. This is the agenda of all of us on public health. So we need to use that argument to make sure that the implementation of the Paris Treaty, and even when journalists are asking us, as they ask you what the scenario on 50 degrees will be, on what it will be for health, my answer to them is, forget about, there is no even estimates for that. We don't want to play with that scenario. That scenario is unacceptable. So it's not even a question of even adapt or resilience. It's absolutely unacceptable. For me, hope as well is coming from mayors, local action. The mayors are the ones that, if you as cardiologists you have a very good reputation and credibility. If you sit down with them and say, listen, if you put in place this reduction of traffic here, I know that this might be unpopular, but look at the science. Reduction of hospital admissions of these diseases, the cost, population, I can help you as a health professional on translating that into health numbers. And they love it. I think the mayor of Paris did something amazing. She reduced 50% in the last 20 years air pollution in Paris. Now you can walk, so you have physical activity, less sedentary lifestyle, and that contributing as well to heart diseases. The mayor of London, because of the asthma, he's an asthmatic himself, and because of the Ella Kisidebra, the case that you all know, he as well put the ultra-low emission zone. So there are many examples at the local level where we can play our influence, that if you use the numbers, say, okay, I can provide you the health benefits, and that positive argument might help you to advance in this.
So, Hatim, are you going to go and talk to the mayor of Bremen now and have a discussion with her?
No, that's the point. That's the point. We need to convince our policy provider that they have financial benefit from it. So how can we do it?
China can give you incredible examples.
So what we need, that's why we need a local data, local research. When we do a study locally and we present it for our policy makers, they have no chance to say no. You see, we could advance them with evidence-based data, so we have the power to change the situation. So it's not only about speaking, but also speaking with arguments.
The AQ Plus of WHO will provide you all of these estimates. I think it's a very useful tool.
That's very helpful, I have to say, for the World Heart Federation, because as I said at the outset, we like to produce internationally relevant policy advice, which can then be picked up at the local level and where communities can change. And I think this shows us a great deal about how the documentation that has already been produced, Mark Miller's document that was published last year, how that can be picked up and then used by cardiologists and mayors and communities to improve things. Georgia, at a practical level, how big is this problem? Do you think this is something that Maria was saying, it's not like tobacco. We haven't got 50 years to deal with this. There are people in Tuvalu who are leaving next year because it's kind of over. Can you talk about, you've got a sense of urgency about this. How urgent is it, and how are you going persuading cardiologists you meet on the train about how urgent it is?
It's a very slow process. It's pretty urgent. I think 2024, we've already surpassed this 1.5 degrees Celsius in global temperature compared to pre-industrial levels, which is what we were trying to avoid to do. So we're already reaching beyond the global temperatures that we were wanting to do. And the research, particularly for cardiovascular disease, is showing within the next 8 to 9 years, death is going to increase by over 200%, by about 230%. So it's serious. Europe is a great example. I feel like every year they have these extreme heat waves, and there's 60,000 people, and there's, I think 2023 and 24 combined, there was 110,000 deaths, excess deaths just due to the heat, and about 86% are cardiovascular related. So it needs urgent action now, and I think I like what Marie was saying before, where you need to almost like flip the script. So don't just tell people the stats of like death and increased risk. It's like, if we take this action, what benefit will we see from it? And I think that's the story that needs to come out, so people are like, oh, I get it. we can actually do something to fix this. It's not just all like doom and gloom, the world's gonna burn.
There is a very broad rule of thumb we have at the Heart Foundation in Australia, which is that we must talk about health for half the time and disease for half the time, because you don't get the message through, you don't get the policy change that you want to see if you just talk about disease. The upside of health is definitely a focus. We're going to go to final questions in the moment, but I wonder we probably have some contributions from the audience which might be burning in people's heads. Does anybody have a crashing thing that they desperately need to communicate as part of this discussion? I'll take that as a no. Okay. In that case, we're going to finish with your soundbite, the thing that you would like most for the World Heart Federation and the world, I guess, but I think particularly the World Heart Federation with our implementation focus. What was the one piece of advice you would like to give us to take away in trying to deal with this increasingly urgent issue? Let's go backwards. We'll start with you, Georgia.
Yep. I think my message would be specifically related to heat. Heat-related deaths are preventable, but we need to advocate and we need to educate, and our health professionals are going to be the forefront of helping that advocacy happen. That's my message.
Fabulous. That's a good handover to Hatim, who is himself a health professional. So over to you, Hatim.
I wish that the World Heart Federation supports local research so that we could have arguments to speak with our policymakers.
And Maria.
I think if we use the positive health arguments, we can move mountains. And my message will be, don't underestimate the influence that as a cardiologist or a clinician you can play. Whether you live in a big city or a very small one, please make sure that you have a copy of the RQ Plus and how to estimate daily information about the levels of air pollution in your city or locality, and then some posters where you practice, where the patients can see the connection between air pollution and health. And my recommendation would be to use heat waves or air pollution to visualize for the patients and for the cardiologist and not convert it. Because if you say climate change and health, but air pollution and health is people grasp it much better.
Terrific. Well, look, thank you, Maria, Hatim, and Georgia. I'd also like to thank Lana Raspal and Sarah Hamidi, who have helped us enormously in preparing for this with great background documentation. And thank you all for being here. So, thank you.
Thank you.